start our recording. Here we go. So I'm Amy Hargan, Director of Substance Abuse Prevention and Education at the University of South Carolina in Columbia. Glad to have all of you here today for the November meeting of our Carolina Community Coalition. We're real excited for the conversation that we're going to have today. And again, I'm apologizing for the background noise because I am in our university union today. To get us started, if you have questions, we'd like you to introduce yourself in the chat. Tell us your name, where you're from, who you are, all of that. We also have the fancy webinar feature, and so we can use the Q&A to ask questions of our speaker as we go through. So feel free to use that to ask questions. Emily, I'm wondering if you would be able to read our introduction to our speaker, since I'm in kind of a loud place at the moment. I'm going to put Emily on the spot.
I would be happy to. I'm always happy to introduce another Emily, so this is good stuff. But I should introduce myself as well. I am Emily Mathias, the coalition coordinator, and one of the coalitions I help be the administrator for is the Carolina Coalition. So thank you everyone for joining us. I'm happy to introduce Dr. Emily Baker. Emily Baker is a postdoctoral scholar in the College of Pharmacy at The Ohio State University. She received her master's in clinical mental health counseling from the University of Cincinnati and her doctorate in counselor education from OSU. In her current role, she serves as the coordinator of the 2022 College Prescription Drug Study, a mouthful, a multi-institutional survey of undergraduate, graduate, and professional students examining their non-medical use of prescription drugs. Dr. Baker is also an instructor of undergraduate and graduate level coursework on drug misuse and addictions counseling. As a certified prevention specialist and licensed professional clinical counselor, her clinical and research interests are focused on interprofessional collaboration and substance misuse prevention and treatment through harm reduction, trauma-informed, and social justice lens. Thank you, Emily, for joining us, and look forward to your presentation.
Thank you so much. Let me go ahead and share my screen here. Can everyone see that okay? Give a thumbs up from one of our folks. All right, so thank you so much for inviting me to present today on the key findings from the 2022 College Prescription Drug Study. This study concluded in May of this year, so this data is very recent, and it's great to look at the findings that we have as quickly as we can after we get that data and make some informed decisions about it. So I'm excited to share some of the data points with you, and I will say that there is a lot of graphs today, a lot of data points to provide you with. I may go through those faster than is your preference, and so I will provide the slides at the end of today's session. My PowerPoint was just having a bit of a fiasco, so it wouldn't let me download it as a handout version. So I will get that done and have that out to you all. But I do want to drop in the chat a link to the College Prescription Drug Study webpage, which includes the key findings reports, as well as the descriptive report, and a lot of different research briefs that we're continuing to develop, many of which I will present today, and some of the data points. So those resources are there for you. But today I'm going to cover a few things. The first is just to give you an outline of what the College Prescription Drug Study is, as well as the key findings from our 2022 administration. I'm going to explain some of the differences in college students' self-reported non-medical use by a few key demographic and academic variables. I won't do a ton of the stratified data today, just for sake of time, but again, those research briefs are available on that webpage linked in the chat. And then lastly, I'll give a few examples of how to use the data presented to inform your prevention planning and strategic plans on your campus. So throughout today, I will be alluding to the non-medical use of prescription drugs and using that phrase pretty interchangeably with prescription drug misuse. And this is the terminology used within CPDS when we present it to students in the survey. And this just means the use of any prescription drug for any reason, any manner, or any time period not intended by the prescriber of that medication. And for CPDS, we focus in on 3 different prescription drug classes: pain medications, prescription sedatives, and prescription stimulants. So with that, we do a multi-institutional survey of college students, from undergraduate all the way to professional students, to understand the non-medical use of their prescription drugs. And that's in collaboration with a number of different offices at Ohio State University, but we like to partner then with multiple institutions to administer this online survey to random samples of different institutions. And then pair with those institutions to understand a few things at the institutional level as well as across them. And so some of our aims within the study are to understand the types of prescription or non-prescription drugs that students misuse, the demographics of students or students who maybe are more at risk for misusing prescription drugs, their reasons for use, as well as their attitudes towards the misuse of prescription drugs, and any linkages that we can find between the misuse of prescription drug and that of non-prescription or sometimes deemed illicit drugs. To give you just an idea of what the scope is for the study so far, we've had 3 administrations that have been multi-institutional level. And all the states here colored in red are states that have had at least one institution participate in at least one of the administrations of CPDS. So we can see already very quickly that many regions are not represented at all or not accurately represented. And so we are a multi-institutional study, not a nationally representative one. And that comes with not generalizing. We don't want to inaccurately generalize some of these data points, but we are getting just a scope of the issue across several institutions. So as we move into data points, of course, we are all aware of strategic planning on campuses. I just want to kind of bring back up SAMHSA's prevention framework, the SPIF, and how CPDS fits into that. CPDS really gives a ton of information and large amounts of data on just this first step, the assessment. And so it's our job then to take that and make sense of it and create sustainable change from the data that is presented within CPDS. So the SPIF, of course, is one of the best frameworks to move forward and make sense of that assessment data by providing a process for translating the data into priorities and then aligning your priorities with implementation strategies. So hopefully we can use the data to make data-driven decisions. And so CPDS fits in by giving us information specifically on risk factors most prevalent in the community for prescription drug misuse, protective factors that are most lacking in the community, the at-risk developmental periods or even time points within college that are most at risk for use or initiation of misuse, what factors need to be addressed first based on the magnitude or the severity of the issue, and then hopefully a cluster of risk factors that if we address them together can provide a more synergistic response that we can target and tailor prevention to address multiple at-risk groups at once. So without further ado, let me share with you some of the key aggregate as well as some of the key stratified findings from today. Again, I'll share these graphs with you at a later point. One of the first questions we ask is how many students have ever misused a prescription drug across those 3 drug classes at any point in their lifetime? And so to give you an idea of where we were at in 2018, we saw that 9.1% of students reported ever misusing a pain medication at some point in their life. 9.4% reported that for prescription sedatives, and 15.9%, nearly 16% of the students in our 2018 sample reported misusing a prescription stimulant at some point in their lifetime. So if we look at 2022 now, we see a decrease in all of those drug class categories. And so we have about 6.8% reporting that they've ever misused pain medication, 7.8% for prescription sedatives, and nearly double those 2 categories there is prescription stimulants at 14.5%. And so while we can see that the trend here is that's going down, these are different samples, different regions, different institutions that participated in the 2018 versus the 2022 sample. So we don't want to necessarily draw too many conclusions from that trend. So if students respond yes to one of those questions, that they have ever misused a prescription drug for non-medical reasons, we ask a series of follow-up questions to better understand their use patterns. And so one of the first questions we ask is about the frequency of their use for non-medical reasons in the past 12 months. So just to orient you a little bit to the graphs that I'll share for the remainder of this presentation. In orange, in the far left here, we have pain medications represented by this color orange. Blue is representing our prescription sedatives, and purple is prescription stimulants. And so in this graph here, we see that for students who have ever misused a prescription pain medication, or students who have ever misused a prescription sedative, most of which have not done so in the past year, which is great news. On the other hand, we see prescription stimulants, a little over half, about 56%, are reporting that they have misused at least once within the past year. Again, that's for students who have ever misused. So I'm going to share that same data point, but now stratify it by a few key variables, some demographic and some academic. I'm only going to do about two demographic variables, the first of which is the self-reported racial and ethnic identity of our participants. So again, at the bottom, we have an x-axis, the stratified variable, the self-reported racial or ethnic identity. And we can see within each, these are the within group percentages. So 1.1% of Asian or Asian American students reported ever misusing a pain medication in the past year. So when we look at the stratified data, we can see a few things. The first is that really across many groups, we see that students are most likely to misuse a prescription stimulant in the past year and within their group. And so with students who identify as Middle Eastern or Arab American, identifying with the highest likelihood of prescription stimulants. So this graph looks a little bit different than other graphs that we see for alcohol and marijuana misuse. One, most students are not misusing prescription drugs in the past year. We see pretty low percentages here, which is good. But two, there's differences now between our alcohol and marijuana use, in which we see larger proportions of white students misusing than students of color. For prescription drug misuse, we can see quite similar within group proportions really across the board here. For pain medications, we are seeing that folks who identify as Hispanic or Latino, Middle Eastern, or multiracial have higher within group proportions. And then we see that Asian American identifying students are reporting the lowest rates across all three prescription drug classes. The last data point I just want to point out here for the stratified graph is that another race not listed is the second largest group in this stratification. So right behind our students who identify as white or Caucasian. And so even within this graph, we get some ideas of how students are impacted by different racial and ethnic identities, but we have 847 students that we don't know really the experience or how that differs for them. And so more focus and more stratification are needed. Just going to show that that same data point in terms of self-reported gender identity. So although we did have students who identified as transgender, intersex, or another gender not listed, we did not have really a large enough sample for those gender identities or enough students within those identities to really report on the misuse patterns. We couldn't draw accurate conclusions. So already we can see that we need more representation of many different groups. But within this, we see cisgender males and folks who identify as genderqueer and non-binary having really similar proportions for all three drug classes. And those students are showing higher rates of misuse within the past year than our cisgender female students. Cisgender females are reporting lower rates across the board for these drug classes, and yet they represent 65% of our sample. And so when we think about some of the aggregate data points that I'm going to share throughout the rest of this presentation, those aggregate points probably represent more so of our cisgender, female, heterosexual, white females. And so it's important to come back to these stratified data to understand the voices that are really missing in the aggregate points. So let's look at that same, again, percentage of students who misuse a prescription drug in the past year, now by a few academic variables. The first here is by class rank. We can see very clearly that there's a trend from the first year of undergrad up to the fifth year plus of undergrad, most distinctly, obviously, with our prescription stimulants, where the higher the class rank in undergraduate, the more likely they are to report misusing a prescription stimulant in the past year. If we think about prevention here, we can see very clearly that our first and second year undergraduate students are in a very vulnerable position. They're about to step into a culture and maybe this trend in which this is normalized, or they have misperceptions that they're facing. So prevention messaging that's tailored towards freshmen and sophomore students who are just entering this trend may be very useful. I also want to point out that our third year undergraduate, our juniors, and our graduate professional students have really similar rates of prescription stimulant misuse. So when we think about this being an undergraduate issue, that isn't always accurate. We do have graduate students that are also impacted and misusing. Okay, so the last stratified data point I'll share with you today is by self-reported cumulative GPA. So we can see, again, a really clear trend across all three drug classes that is occurring, where students' self-reported GPA is inversely associated with prescription drug misuse in the past 12 months. And that is obviously most distinct, again, by prescription stimulants. In the relationship, we are seeing actually really speaks to this common misperception that I'll speak about in just a moment, that students are misusing prescription stimulants for academic reasons. That's not a surprise to all of us or many of us. And yet when we look at the data in terms of the cumulative GPA, we see that it's not accurately impacting in the way that students perceive that it will. So speaking of reasons, our top reasons that students are reporting in CPDS for misusing a prescription drug are presented here. There's the top 3 reasons across these drug classes. When we ask this question, we ask it in a multiple choice, select all that applies. So we have things that are very clearly represented in the top 3 here, like relieving some sort of concern, like feeling better, relieving some side effects, helping with mental health, etc. But we also ask about some common misperceptions or social norms for use that are not seen really in here. Those include things like they misused a prescription drug because they believed it was safer than other drugs, or they had an easier time accessing it, felt it was less illegal, things like that. So across the board, we can see a few differences based on the medication in which they are misusing. For pain medications, we have 46%, just under half, reporting misusing to get high, 41% reporting to relieve pain. For sedatives, relieving anxiety and sleep are the highest reported reasons. And then unsurprisingly for prescription stimulants, 3/4 are reporting that they're misusing to help them study or improve grades, which of course we just saw that graph that doesn't actually correlate into potentially higher GPAs or improvement of those grades. And still nearly 1/4 are reporting using prescription stimulants for other reasons, like enhancing their social situation or to experiment and see what it feels like. So that's why they're using. We also want to know what comes of that use. So in 2022, the sample reported across the board that feeling or being depressed was one of the consequences of their non-medical use of each of these prescription drugs, as well as emotional problems or doing things that they wish they hadn't, some regret. All of those things, exasperate some of the higher rates that we see of mental health concerns in college students. In our prescription stimulants, we see 62% reported perceiving that it had a positive effect on their grades, despite the data not really representing that. Because it's an increasing issue, CPDS really briefly examines polysubstance use by inquiring about a few things. If they've simultaneously use multiple prescription drugs, or if they've used prescription drugs with alcohol. And so this figure just briefly describes the percentage of students who have ever reported misusing a prescription drug, how many have done so with alcohol. So 36.7% of the students who have ever misused a prescription pain medication have done so while drinking, 43.3% for prescription sedatives, and over half of the students who have ever misused a prescription stimulant have done so while drinking. I think these numbers can just be a little bit misleading. Those high percentages can feel a bit misleading without the context. So remember that I shared only 14.5% of the students in this sample had reported ever misusing a prescription stimulant. And so when we look at half of them now using with alcohol, that's about 8% of students overall then misusing stimulants with alcohol. And I just want to pause right there because, you know, these data points that I've presented so far are really some of the key components or data points that I would present to a stakeholder on campus to help them understand the risk, the need, the severity of the issue for students. Because although students are not misusing prescription drugs at the same rate that they misuse alcohol and other drugs, they are intersecting with those things. That alcohol use with prescription drug misuse is occurring. And so it can tell the story of the heightened risks and how those things are occurring for our students. I'll share a few more data points today. One of the questions that we ask is when they started the misuse of the prescription drugs. And unsurprisingly, we see high school and college representing the highest risk developmental periods. So if we look here, we have for college students, 63% of students have started misuse within college. And that is, as we looked at the class rank, of course, our first and second years are the most vulnerable for that initiation. For prescription sedatives, we see that about a split between high school and college. And then prescription pain medications, most students are actually starting to misuse pain medications before they even enter the college environment. And so knowing that information and knowing that really the differences in initiation for different prescription drugs can help us tailor to the students that are entering a first and second year. All college campuses want to know really where are these students obtaining the drugs that they use for non-medical reasons. And of course, unsurprisingly, 77% of the students who ever misused a prescription stimulant received it from a friend, followed by a peer who is not a friend. And so that really speaks to the social norms of specifically prescription stimulants. For pain medications, we see a bit of a different trend here. 44% of them are reporting receiving them from friends, still a very high number, but nearly a quarter of them are also receiving them from relatives or from the pharmacy. So that's how they obtain it, but we want to know how easy is it to actually obtain it from those locations or from those folks. 11% of the students in our sample reported it perceiving it to be somewhat or very easy to obtain a pain medication, 15% for prescription stimulants, and over a quarter reporting that for prescription stimulants. And I just want to point out that this includes all the students in our sample, not just the students that are misusing. So even for those students that are not misusing a prescription stimulant, over a quarter of those students still perceive it that it's something that is fairly accessible on their campus. Okay, the last data point I'll share with you today is just awareness of resources to help with prescription drugs. And so we inquire about awareness both on and off campus. As of 2022, 49% of the students were not aware of resources either on or off campus that could help with prescription drug safety. However, far more students were aware of where to go for help with concerns about the misuse, nearly 3/4 of them. So students are more aware of what to do once the use becomes a concern, but less awareness of the preventative upstream information. So with all those data points in mind, how we then move into translating that data into our practice and our strategic planning is important. And there's just a few brief ideas that I'll share with you today. keeping with the SPIF, we want to assess what the problem is. So asking these questions of what substances are being misused within the data that are presented today, we could see prescription stimulants that have the highest rate of frequency within the past year. How often is that misuse occurring? We saw that for prescription stimulants, 56% of the students had misused within the past 12 months. And 40% of the students who had ever misused have do so at least once per semester. So this is clearly something that's slightly different than our students that are misusing prescription pain medications or sedatives. We also ask when that misuse is occurring so we can gear our prevention programming correctly. About 55 to 70% of the students that misuse report doing so before finals or big projects, and they obviously initiate more likely during undergraduate when we're thinking of prescription stimulants. And then lastly, who is experiencing more misuse problems? I showed you a few of those stratified findings, but we did see students with lower GPA being more at risk, male identifying or cisgender male identifying students. But other groups like veterans or fraternity and sorority affiliated students could be included in that question. Once we know what some of the problems are, we can prioritize how to address those problems. We do so by looking at the magnitude of the issue, which is just understanding the prevalence of that problem, the severity or the impact that it has on the individual and the community. And those are really the two data points that I shared with you in the slides today. But it's also important to know how that's changed over time. So for CPDS, we provide institutions with their institutional level data, and they can use that specific data to then create a program. And then 2 years later, when the CPDS is administered again to their institution, they can assess how did that go? Did it change anything? And understanding the evaluation component of CPDS. And then changeability, how likely is it for the modification to occur? When we think about prescription stimulants, we saw how high the percentage was for reasons for using, academic reasons for misusing. And that is a really difficult perception to shift. So the likelihood for changing that perception, significantly within 2 years is perhaps different than changing something else. With those identified priorities, those identified problems that are driven by that data, we can align strategies. So keeping SAMHSA's guide for implementation in mind, specifically for prescription drug misuse, they suggest having education, tracking and monitoring of prescriptions within the community, proper medication storage and disposal options, having harm reduction, and if at all possible, to have multi-component where we're addressing, again, kind of the synergistic response. We can also, though, align based on varying levels of risk. So I have a few examples here for prescription drug misuse prevention. The universal level, again, proper storage and disposal options on campus, having that very consistently available, as well as social norms messaging. When I think about universal social norms messaging, that should be things that are used at the universal level that can include frequency in which students actually misuse prescription drugs or the lack of impact that those prescription stimulants have on grades. But that would be different than, say, the tailored peer education and social norming that you see under selective. And I think that's often more effective, is to do tailored social norming. McCabe and his colleagues in 2019, they reported on a study where they found that sharing norms for a quote unquote typical student, often what's used in the universal strategies, those students, when they share those norms on a campus with students from an ethnic minority background, is less useful for challenging and correcting norms, particularly for Hispanic and Latino and Black or African American students. So, these students might not perceive themselves to be the quote unquote typical student on campus, and thus the social norm is really geared towards the majority students, particularly on predominantly white campuses, are less impactful for correcting their perceptions. So knowing that and tailoring your messaging to specific student groups, to specific identities, backgrounds, is more influential in general when we're talking about social norm prevention. And then, of course, in our selective, we have study groups helping students understand that other strategies are probably more useful, although there are more long-term strategies for improving their grades than misusing a prescription stimulant. Again, that's a very hard misperception to correct. And some ideas about how to, again, tailor things to specific developmental points that are have higher risk of misusing, as well as students who are more likely to misuse or initiate misuse. So speaking about that tailored prevention, the selective or indicated prevention, just want to highlight a few points from the CPDS slides I shared today that really stand out. First, we want to target first and second year undergraduate students in our prevention interventions. They're stepping into that trend, and if we do upstream prevention, we can prevent them stepping into the trend themselves. We can challenge the misperceptions that prescription stimulants improve students' grades. Of course, I can't say that one enough. Very important to prevention. Tailoring prevention for graduate students, particularly, and as well as these other students that are not represented in our aggregate data. If we only use the aggregate data to then plan our prevention programming, we're missing lots of students that we just saw are experiencing and being impacted by prescription drug misuse. And so that includes graduate students, our BIPOC students, LGBTQ+, and other student groups like veterans, fraternity and sorority affiliated, international students, etc. And then utilizing culturally grounded prevention. So I want to focus in on that a little bit more. Culturally focused prevention includes these 4 steps, and what I highly encourage you to use when you think about implementing prescription drug misuse prevention on your campus. So the first is to determine how the issue impacts the diverse student populations. We did a little bit of that today, but you can continue to dive into that for your specific institution, or by looking at the research briefs that we provided to get an idea of the scope of the issue for diverse populations. But then assessing how your current prevention programs impact diverse students. Are those programs in place actually reaching all the students? Are they driving further inequities for students with marginalized identities? How are they perceiving the prevention programs that you have in place? I think that's really where community participatory research, focus groups, all that rich qualitative data that you can gather from students within different populations is particularly useful. Third, obtain their ideas. Go to the group in which you're trying to tailor an intervention to and get their ideas on how to shape, deliver, or adjust a prevention program to better fit their needs. And then finally, return and assess after the implementation of a program their ability to engage with that program. Were the students able to access the program that was created and tailored to them, or did they feel safe, valued, respected within it? And if they didn't, then you need to return to step 2 and continue that culturally focused prevention. And that really speaks to using one of these 3 different approaches, which is outlined here in Okamoto's study on in 2014, and talks about 3 different culturally focused prevention interventions. The first is the surface structural cultural adaptation, which involves just shifting your prevention programs that you have in place. That might be even just shifting an alcohol and other drug prevention programs to include prescription drug safety. But it also includes thinking about the various groups that are then impacted by prescription drug misuse. If we just include, again, the majority or aggregate, we're missing a lot of students here. A further adaptation includes this deep structural, where there's substantial changes to the structure, design, or the content. It takes more time and it can be more challenging to make those adjustments, but more useful overall for the groups that we're trying to tailor and reach. And then lastly, the culturally grounded prevention, where cultural competence is not an afterthought here. It is the center for building up a prevention intervention. And so it is obviously more expensive, time intensive, but the the groups in which you're tailoring to are included in the development, the implementation, and the evaluation. Their voices are heard at each point. And so when you're thinking about prescription drug misuse and how you want to take this data, I just really kind of keep emphasizing that listen to the groups of your campus and what they need, because I can present a ton of multi-institutional data, but what's occurring on your campus and within these different student groups is far more important. If you want to know a little bit more about the national key findings or some of the research briefs that we've done, that includes stratified data, some research briefs on fraternity and sorority affiliated students, and some other items, you can visit that webpage that I linked in the chat earlier. You can also send me an email. The study email is rxstudy@osu.edu. I try to check it very regularly, so please feel free to reach out if you're interested in knowing more about the study. And then if you're interested in participating, the College of Pharmacy is recruiting up to 50 institutions for the 2024 administration. And so you can also send me an email, that same email address, to just be added to the recruitment list. The administration plan is available on a webpage to understand the timeline of the study and the requirements for participating institutions. However, that timeline is adjusting a little bit for the 2024 administration. We will likely start, our recruitment process at the end of the spring semester, if not earlier. So please feel free to reach out with any questions you have about that study. And I'd love to take some questions and know how you all are doing this work on your campus.
Thank you so much, Dr. Baker. Really appreciate you sharing the information and how thorough the report is. So thank you. I feel like every time I hear you talk about this study, I learn something new. So I appreciate that. And I also want to make a note that I can see from our participants that we've got several folks from some of our area smaller campuses. So I know there's folks from Columbia College and UC Aiken, and so I think there's a great opportunity there. I hope some of them will kind of take you up on that opportunity, because there's not a lot of small schools in the sample or in a lot of other studies like this that are multi-institution. So I think the more opportunity we have to have some diversity in institutions, right, then the better chance we've got, just like you were just talking about, for culturally competent interventions for our campuses, we've got a better chance of having good comparison data for our smaller schools. So
absolutely. And I think CPDS is very interested in having 2 4-year colleges having large, small institutions. So if you're interested in your college campus, please reach out. So
great.
love to have more of that.
Well, we are going to do some questions, and folks, if you have questions, you can put them in the chat. You can use the Q&A, and we can talk as we go along about different things that brought up. I know Dr. Baker, you often are asked about lots of different ways that you disaggregate the data. So I appreciate what you were able to share. I wonder if you, what strikes me often is that it's kind of the same problem children who are the ones who come up over and over again. It's our white, cisgender, male troublemakers. And so I wonder, do you think that in that study, is there more use of other substances? Like, are they using everything and also prescriptions, or is it limited to like they just are using prescriptions a lot?
So what I wasn't able to present today, but I have included in other spaces, is also included in the research briefs, is that male identifying students particularly are reporting that higher use, but they're also misusing with alcohol more likely. So they're more likely to misuse alcohol, more likely to misuse prescription drugs, and they're more likely to do that together. And we can see that for a couple of groups. But outside of alcohol use, we haven't done enough analysis to kind of dive into what other drugs have they reported misusing. So still working to disaggregate and stratify some of these findings for some of those variables.
And I think that informs how we think about our interventions too, right? So places where we're already interacting with students who are high risk white male students, screening them and asking them about what other drugs they're using is an easy kind of low level strategy to add in, to just kind of assume like we need to ask these folks some questions because they're more likely to be using more than just the alcohol they got in trouble for, as an example.
Yeah, and I think that sometimes prescription drugs is like missed in those questionnaires, missed in that screening, or students just don't think about that when we ask about drug use.
Yeah. So Andrew's got a good question in the chat. I do know that you were specific to prescription medications, right? So nicotine and caffeine wouldn't have been included in that category of stimulants. But he's asking about, were there control questions to ensure that students are not prescribed medication grouped into that category of students who are being reported as non-medical use?
So we do ask students if they've received a prescription for one of these drug classes in the last year. And then we give this definition of, no, it's not non-medical use, it's not misuse to use that as prescribed. But if you've used more of it than it was prescribed, then we want them to include that in how they answer their misuse questions. So provide that definition that I gave for the non-medical use of prescription drugs at the beginning of the survey, so they're aware. We also give them just examples of what those drugs might be. So the student, we tell them, have you ever misused a prescription pain medication? We give them examples of what that is, including all of them. So good question.
Great. Thank you for that. I think McCabe and some other folks have found that those students with legitimate prescriptions often are experimenting with them a little bit, having some extra, taking it only when they have a paper to write or an exam to study for. And so that is one of the pathways for misuse, is having the availability of a legitimate prescription.
Absolutely. I think that speaks to just really involving the pharmacy, involving providers, and how they talk with folks that they are prescribing these medications to, and really that, again, multiple levels of prevention.
Let's see. I love that you brought us back to the SPIF and reminded us that when we use a prevention framework and do some strategic planning, we're much more likely to be successful. And I will share out the link to the DEA prevention guidebook for prescription drugs. That's actually very, very helpful resource for this. So thank you for bringing that up. I wonder if you could talk about policy. What are some of the things you've seen or have been talking about in terms of what do we do with our policies around these substances?
Well, for prescription stimulants, that's probably the one I can speak primarily of. They have discussed, especially on Ohio State campus, we had recently the death of 2 students from pressed pills that were prescription stimulants. So using this data, now policy is shifting maybe faster because of sometimes these tragic incidents get stakeholders' attention more than my data slides will. And now we're seeing some policy shifts in terms of harm reduction that's available. They're starting to think about what's available within dorms in terms of proper storage of medications, as well as the disposal of those medications. It's not just one disposal day. We want to have really accessible disposal options throughout the year, and getting students to be aware of those in the first semester that they're there by having them in dorm rooms. So some of those policies and shifts are, I think, pretty significant and need to be really occurring on all campuses. But I think some of the other policy shifts is how we then address diversion issues. When medications are diverted, how do we become aware of those? And then what do we do with those students that we are aware of doing those types of behaviors? and linking them then to the resources on campus. So I think there's lots of zero tolerance still in place, or watch this video, take this class. And sometimes that is less effective than other strategies. So some of those policy shifts are happening just slowly based on the state, based on the institution, the awareness of it.
I know, Andrew, I'm not ignoring your question. I just have one more policy thing. And I know we have several campuses represented, so I'd love to hear from some of our other friends in the state. But one of the things the folks in the SEC wellness directors have been talking about lately is library hours. And what is the message we're sending to our students when we have libraries that are open 24 hours during exams? And does that encourage healthy behavior, discourage healthy, is it good that you're studying, not bothering your roommate, and you have a place to go at 3 a.m.? Is it not a good thing because we're telling you should be studying at 3 a.m. instead of sleeping? I wonder if that's a conversation on your campus or anybody else.
I have
Feel free to
not
jump in.
heard that yet, but that is so interesting because there's probably misuse happening in a very contained way in the library, and then misuse happening outside with alcohol and whatever else. And that's very interesting. I would love to hear how OSU and other campuses are addressing it too.
Yeah, I think it's a mixed conversation because I think there are students who want to be able to have that access to a quiet place to be if they need to study, if they reach that point. And others of us are saying, but also you need to go to sleep. you need to sleep some too. If you're studying.
Well, we did see, how high the misuse of prescription sedatives is still. I hyper focus on prescription stimulants because they're higher frequency, and that's more likely to have diverted. But prescription sedatives, lots of students struggling with anxiety and sleep issues, and then turn to those after misusing a stimulant. And so,
right,
absolutely, those issues need to be addressed.
Well, and it's a spiral, right? So I'm drinking Monster and energy drinks and stimulants to help me stay awake, and then I can't get to sleep, so I'm using a sedative to sleep, and none of it is helping my grades. And so they ended up at the end of the semester in a real state, mentally, physically, and not with the grades that are great.
Yeah.
Marguerite added that at Coastal, the library closes at 9 regularly, but is open 24 hours during exam. Midnight regularly, and then 24 hours during exams. And I think that's pretty common on our campuses. And so our library Starbucks had a billboard, sidewalk sign out front the other day that was basically saying, "We're sure you haven't slept, so come in and get a giant coffee." And I had feelings about that.
Yeah, I have feelings about that as well.
Andrew asked about the gender differences.
Yes.
If the variables were weighted and the big gap between male and female respondents, and I think male, female, and non-binary respondents, there were some big differences.
Yeah, let me pull that slide right back up. Can we see that stuff?
Yes.
Okay, great. So yes, we do. So they are not weighted in any of these descriptive graphs. So not weighted, but we see within group differences. So 6.4% of the cisgender male students are reporting. So 6.4% of their sample. So that's a great question. We just see similar percentages or proportions within those students for male and genderqueer non-binary. But of course, because we have a higher sample, that cisgender males are reporting as higher use. And of course, we have a much higher female sample than we do cisgender males. So when we see 3.5%, that there's a ton of females that are misusing still. It's just in terms of within group, we see a little bit more significant within group proportions for males and genderqueer.
And we know that women are prescribed sedatives more, but men are prescribed stimulants more. So there also may be a piece of who's diverting to their friends in that.
That we are trying to focus in on some of these stratified data to do some peer-reviewed research and get some manuscripts out that include some of this weighting of the data and moving past just the descriptives. So hopefully looking at the prescription rate and how that influences or predicts some of these behaviors.
And did you see any differences over time? This is what, the third administration. Are there any big trends or differences?
So, we've been talking about how do we want to present some trends that we're seeing, and kind of decided to draw back in providing trend information because there's such different samples. And it's kind of a self-select for institutions that they decide to go ahead and join the study instead of having it be representative. And we want to do that not to create a nationally representative sample right now. That's not our goal. It's to get institutions an institution-specific report so that they can use that on their campus. So that's the goal and why we haven't really done a ton of data analysis around trends. We have seen when we look at pain medications, prescription stimulants, and prescription sedatives separately over the past 3 administrations, most students that have ever misused have not misused in the past year, and that is going down pretty steadily. So
that's maybe some good
speaking
news.
a little bit to prevention and recovery oriented.
Great. All right, folks, any other questions in the few minutes we have left? Give people a minute for that. Any ways that you would suggest that campuses and work with their local communities? I know you mentioned pharmacies, thinking about diversion. What are some of the strategies for involving our communities?
So I think one of the things that stands out to me is when the initiation of prescription drug misuse is occurring, particularly for those pain medications and sedatives, which are occurring or happening at higher rates than prescription stimulants in high school and middle school. And so the community, how are we preparing students before they step into the college environment? How are we engaging conversations at the high school level, 12th grade level before they get there? What's the first year experience like? I think those community-oriented programs are more useful for pain medications and prescription sedatives. And then in college environment, as soon as they step into those doors, having more interventions that are targeted for prescription stimulants.
And the reasons they're using them, right? I think the motivation stuff is so interesting because they're using stimulants for a very different reason than the sedatives and the pain relievers. So our prevention needs to look different for those substances if we're going to target that difference in motivation.
Yeah, and very different perceived consequences of them. Mostly positive view and that social norms perpetuation that's occurring.
Right. Well, great. Thank you so much, Dr. Baker, for sharing this with us and for spending your time with us today. We really appreciate and value the work that y'all are doing, and hopefully we'll make sure the information is out for our campuses across the state to join into the next round of the study. Thanks to everyone for joining us today. We hope you will come back in December, the first Thursday at 4 o'clock, where we will be talking about impaired driving and hearing some of the new research and old research about what's happening with impaired driving for college students, particularly since the COVID pandemic and how that has impacted stuff. And some of our law enforcement friends are joining us on that, which I think will help give a good picture for the conversation. So hope you'll join us for that. And thank you for being here.
Thank you so much, everyone.